Thank you very much, Dr. Zias. I am joined here by my colleague, Lauren Gillis, who's a nurse practitioner and the director of what we've created, which is a post-surgical ablation surveillance clinic. And I'd like to kind of take you through that now and the impetus of how it got started and how we feel that this is absolutely critical for surgeons to improve their technique, primarily by learning what their outcomes are. The other thing that it does is it dramatically improves some of the post-op management, post-maze, which we felt was falling through the cracks. Now, the left atrial appendage management, we had to go through a little bit of a journey on. We started with TEEs on these patients, all of them, and the patients hated it and it was difficult to set up. But we have an advanced imaging center here, and luckily with the Watchman, they've set up a protocol that apparently is used all throughout the country called triple flash imaging. And with this, you can get very sensitive, high accurate images of the left atrial appendage to determine how well it's excluded or not. So we've moved to that. The patients are tremendously happy with this change. Now, I'm going to turn it over to Lauren here just a little bit, but we see them for a total of 5 major points throughout the year and annually. And yeah, just kind of speak to this quickly.
So this is our schedule of visits. They come in for the 1 week and the 3 week. They're pretty much your post-op checks. We also see them about 7 to 10 days after discharge. But we do get the EKG there, pretty basic visits. The real meat and potatoes is the 3 months where we start putting on the Zio patch for 7 days. And as long as that comes back negative, we can get rid of those antiarrhythmic. And then the same thing repeats for 6 months, and then yearly we'll put the Zio patch on, and then at 6 months is where we can talk about getting that blood thinner off. That's usually about the time where we order the CAT scan. I should point out on these slides that we don't order that CTA every single time. We're just getting 1 scan. And so that repeats every year for life. And I'll tell the patients, this program has been well received by them. They, in a lot of cases, look forward to getting these monitors on because they want to know, did the procedure work? Is their AFib gone? And more importantly, they want off of these medications. So that 6-month visit is very important, and they're very happy for the most part to be off of it. So we've had great success with that so far.
Now, we do this in collaboration with our EP physician. So Lauren is in a multidisciplinary clinic where she works in between both groups. And if there's a question or if an event monitor comes back and we're not sure, or if we have a failure, we immediately bring in the EP physician who is in charge of that patient. And if for some strange reason there wasn't one assigned, we get them assigned. So now a couple words about left atrial appendage management. If there was ever a proof of concept, this kind of clinic is key to why you should be looking at this. Not all of the appendages were successfully excluded. And being able to identify that when you're having that discussion with the patient about whether or not you're going to come off anticoagulation really is critically important. Interestingly, the clips have worked beautifully. It's the stapler that we're having issues with. And right now we've got about a 40% pouch rate with the stapler. Now again, that's 1 or 2 surgeons that have been championing the stapler, but as they get this data back, they're moving away from the stapler. It still is a conundrum when you have a patch here or a pouch, a residual pouch in the left atrium, the left atrial appendage, about whether or not you can safely take that patient off anticoagulation. It's a big debate. We do it with our electrophysiologists. Right now, we're leaving them on anticoagulation if they still have a stump. So here are our future goals. But really, I think at this point, we're on to something. It's this process that we're doing, I think, needs to become standard for every serious program out there. They're just not going to be able to get better until they see what their results are. That's how they're going to know that they have a problem. It beautifully bridges the multidisciplinary hurdle by allowing you to work with the electrophysiologist. They love this. They initially were very much into kind of letting us go off to look at the post-surgical side of this, but now they're warming to what we want to do in phase 2, which is to wrap all patients, EP included, into this exact surveillance program. It's then that we're really going to be able to generate some powerful data about what is truly effective at a 3 or 5 or longer window and what's cost effective for quality care with patients with atrial fibrillation.
Another question I have for you is your maintenance of your left atrial appendage clip. So, as I assume the rest of the group believes, as I do, these things don't move. So that when you have a bad appendage clip, has nothing to do with the clip. It's how it was placed. So, do you check everyone with the CT, even though they've had an intraoperative PE that shows adequate closure?
We do.
And the second is, what is your criteria for adequate closure by CT scan at 3 months down the road?
So the little bit of the troubling part about the TE is it's operator dependent. And the CT scans, the flash CT scans, take that whole part about did it move or not completely off the table. So, we do that down the road where if there could have been any movement, it would have already occurred. And it's interesting to see the data on the clip is fantastic. Now, the CT scan protocol is specific for the appendage and not just with the clip, it's also there for the watchman. And having that standardization in place really takes out the error that you may get from provider to provider with TE.
So what is considered, Dr. Philpott, what is considered a failure of placing the clip? Meaning, do you have a specific a way, meaning if you have a pouch of less than a centimeter, that's considered success. If it's over a centimeter, it's a failure?
We've gone by what the advanced imaging physicians are calling for that. And yeah, it's actually under that. If there's any residual pouch at all, they're calling that a failure. So it's sub 1 centimeter. And when you see the scans, it's actually, I have found it to be very powerful for the referring doctors. The clip tends to exclude the appendage very flush. So it's almost a smooth taper. Whereas with the staples, the failures that we've had, when you look at them, they're a bit concerning. I mean, you really want to get these people off drugs, and there is data out there to suggest that leaving a pouch may be more dangerous than not doing anything at all to it. So, so the picture says 1,000 words, so to speak.